So welcome everybody to the EPOCH showcase. My name's Jo Mitchell and I'm going to help facilitate the discussion today. I'm really excited. I think this is going to be a really enjoyable but also a day where we learn quite a lot, both from the work that EPOCH has been doing over the last several years, but also hearing from policy partners about what's important to them, both in terms of the topic area, so the prevention of overweight and obesity in early life, but also in terms of how research can make a difference to policy as well. For those who don't know me, I was formerly the Executive Director of Population Health in the New South Wales Health System, and so part of my responsibilities included a focus on overweight and obesity. But my history, I've had a long connection with nutrition, having studied as a dietitian back in the 1980s, and having had a lifelong interest in and passion for healthy eating. And I've been lucky enough to be able to continue that thread throughout my career. So welcome. As we start, I would like to acknowledge that the traditional owners of the land, and from where I'm joining from, that's from the Gadigal land, part of the Eora Nation, which is part of the Sydney Basin. So I think that that we are now becoming much more used to and build in as part of our regular business and acknowledgement of country. And I think this is such an important part of our new ways of working, I think, and there's a lot more awareness, I think, about the importance of acknowledgement of country and respect for elders past, present and emerging. So you can see there this great map of different countries that people are joining us from, and so clearly quite a few from Gadigal. Also, I note Ngunnawal country as well, so quite a few from the Canberra region. I'm not familiar with all of these lands, but I think that's a beautiful word cloud, which demonstrates an acknowledgement that we are meeting on Aboriginal land, and that from one of the benefits of working virtually is that we do join and can see that there are many lands that we are joining from. So today, the focus of today is to provide an opportunity for the EPOCH team to present their key results. And as you know, the focus is around childhood obesity from an early childhood perspective. And so we'll hear about the research results, but also part of today is about a dialogue. It's about talking about how Australia can move forward in this in the prevention of obesity, but also about the opportunities for wider collaboration, both in terms of future research, but also other policy and practice-based activities. The session today will follow a pretty standard format where we'll have some presentations from the stream leads from the different component parts of EPOCH. We will be having that will be about 40 minutes of input. We will have a quick stretch break in the middle where you can stretch, get a glass of water, look out the window, have a quick break from the screen, and then and also that's an opportunity for you to think about questions and to pose those in the Slido Q&A. And then we will rejoin and then have a panel discussion where we've got a terrific panel which of people who come from different jurisdictions, who have different perspectives in terms of the policy angle of this research work as well. And so we will have an opportunity to hear from the panelists, but also to answer questions and of the research and take forward that discussion. So to begin, I'll ask Louise, I'll hand over to Louise, who's going to just sort of set the scene for us in terms of the importance of prevention of obesity from early childhood. So Louise.
Thank you, Jo, and welcome to everybody. On behalf of the NHMRC Centre of Research Excellence in the Early Prevention of Obesity in Childhood, big breath, EPOCH, I too welcome you to this national dialogue on addressing obesity from early life. Now, folk, I've been a doctor for over 40 years now, almost all of that time working in paediatrics, largely in Sydney. When I was training to be a paediatrician in the 1980s, we rarely saw children with obesity. Type 2 diabetes did not exist in childhood or adolescence, and the only people with sleep apnea were those with craniofacial abnormalities or prematurity. Now, we fast forward to the 2020s, and obesity itself affects 1 in 12 children in our country. Type 2 diabetes occurs in children of primary school age, and the main reason that children are now on CPAP therapy is because of sleep apnea secondary to obesity. Further, we see children with fatty liver disease, with depression, with orthopedic problems and more, all secondary to their obesity. And we also know that obesity carries health risks of health problems into adulthood. So I see children like this every day in my day job as a paediatrician at the Children's Hospital at Westmead. And while I know that it's really important to manage these children, and I feel passionate about that, I and my colleagues here are also absolutely passionate about the fact that the problem also needs to be prevented in the first place. So this then brings me to say, well, why are we interested in obesity prevention in early childhood? Well, we know we need a life course approach to tackling the prevention of obesity. This is an issue across the life course, but there's an important element in early childhood. Interventions in early childhood are especially important because high BMI in early life strongly predicts lifelong weight status. And at the moment, when children start school in Australia, 1 in 4 are already affected by overweight or obesity. So if you wait to school entry to start to do something, it's too late. It's also, childhood obesity is also unequally distributed among priority population groups, with higher rates among those who are Indigenous, who are culturally diverse, or who are experiencing social disadvantage. We also know that a lot of the really important health-related behaviours, such as diet quality, physical activity, sedentary behaviours, and sleep quality, are actually established in and tracked from early childhood. So let's get in early and try to get on the right track. And we also know that intervening early in life, when biology behaviours are more amenable to change, are more likely to have sustained effects. So that's the rationale why we're interested in early childhood. And that's why our group of researchers and practitioners with links to policymakers established the Centre of Research Excellence in the Early Prevention of Obesity in Childhood, EPOCH, which has been funded by the NHMRC since 2016. We've brought together a diverse team of senior and more junior experts from around Australia, New Zealand, and beyond to bridge the current gaps in our understanding. We've got people working in health promotion, early childhood nutrition, child physical activity, health economics, statistics, growth modelling, next generation models of evidence synthesis, paediatrics, primary care, policy analysis, and more, all involved. And our lead in universities, you can see now in the screen behind me, the University of Sydney, Deakin, Flinders University, QUT, and the University of Otago. So our group has been working for now 5.5 years and in 4 interrelated research streams, been analysing interventions to prevent obesity in that early age group. We've been assessing obesity-related behaviours. So how do you advance our understanding of how to do that? Economic evaluation of early childhood obesity prevention, and translating evidence into policy and practice. Today, you're going to hear a summary of that work over the last 5 years, but we mainly want to look forward. We are very keen to get ideas from as many people as possible about what should be done over the next 5 years as we continue to work together. Now, as you listen to the conversations today, I want you to remind you of the policy context. At an Australian level, the Australian government is developing a national preventive health strategy and a national obesity strategy. Each went out for broad consultations in 2019 through to early 2021. However, the launch of each of the two strategies is still awaited, delayed due to COVID impacts. At the level of the various states and territories, there is a diversity of policy contexts. Many of these jurisdictions have policies on childhood overweight and obesity on the early years, so the first 2,000 days, and on healthy eating and active living programs. So please bear all of this in mind as we reflect on the work of EPOCH and plan for the future. So thank you all. Thank you for coming. I will hand back to Jo now.
Well, actually, I think we are now going to have a short video which does a cook's tour, I think, of the EPOCH, and then we'll move from that into individual presentations.
Obesity is a really complicated space. No one thing is going to fix it.
One in 4 children in Australia are affected by overweight or obesity at the time that they start school. Obesity is associated with a range of health issues. Of course, as you get older, the health issues become more profound, but even in young children, aged 3 to 5, those with obesity are more than 1.5 times as likely to end up going to hospital and to having an operation compared with those of healthy weight. Our group is really interested in, can we try to turn things around by starting in those first few years of life? Generally, people tend to work in their own research groups. My silo, your silo. What we've done with EPOCH is to try to bring people together in a collaborative approach. We've deliberately organised streams of work with people working across universities and across states.
Measuring obesity-related behaviours in young children is a really crucial part of obesity prevention efforts. We found that really there was no fit-for-purpose tools out there, not in Australia or even internationally. And the tools that were available either only looked at diet or activity alone, and also they could be very burdensome, they would be very long. The tool that we've developed is as simple as 10 questions, and it takes less than 5 minutes for caregivers to use.
The primary aim in our stream was to be able to do economic evaluation of interventions to prevent obesity in early childhood. You can actually evaluate lots of interventions, and the idea really is that we can look at what is the best value for money. So we never have enough money for prevention, and to use money wisely, we really would want to use it to fund those interventions that actually give you the best benefit for the money spent. So it's all about value for money.
It's interesting bringing together people from very different backgrounds to listen to and learn from health economists, really amazing statisticians, health promotion practitioners, people who are experts in the measurement of physical activity or nutrition in childhood, people who work with culturally and linguistically diverse populations, people who actually think about how does policy get implemented and how do we resource that in a state government department, and learn about that. And we can't do our work in early childhood unless we have that diverse range of skills.
The states and territories are quite committed to act in this space, and so they have collectively tried to develop the National Obesity Strategy, really without a lot of input from the Commonwealth. It really does drive change, and it's really important to have that structure in place. What we don't do so well is look at those upstream determinants of health, and so things like considerations for the food environments and the physical activity environments. We have a lot of potential to do better. I think when it comes to children, the public are a lot more supportive of policies that are going to be helpful for children.
Part of the EPOCH-CRE Stream 4, we've been focusing on 2 different evidence-based programs. One of them is Infant, which is implemented in Victoria, and the second program is Healthy Beginnings, implemented in New South Wales. Some of the key findings that we found is that it is feasible to integrate and deliver these programs within existing services, because the clinicians that are working in maternal and child health have found that this is part of their core business. They are already delivering this kind of information, but it had provided them with further support. It's exciting to see that both programs are being scaled up within each state, but also with the intention of implementing them on a national scale.
The World Health Organization, in its Ending Childhood Obesity Commission, made tackling obesity in that very first couple of years one of its major strategies. And one of the pieces of evidence that they used is the work that has come from the EPOCH group. That was so exciting. We've got a collaboration that's going internationally where people have agreed to share their data from obesity prevention trials around the world, so that we can better understand what aspects of which interventions work best for different people in early childhood. It's been wonderful to see the new opportunities coming out, the ability to see interventions being implemented, particularly in New South Wales and Victoria. That's so great, seeing those become part of routine practice.
The video.
Terrific. And I'm glad we got through that. There are a few little jumps, but we got through that, which is terrific. And I'll just note that video, I think it's a really nice way, in a very short and concise way, to provide an overview of what's come out of EPOCH, as well as why the issue is important. And it's available on the EPOCH website on the front page. So terrific. And we'll now move into our presentations. As I said, we'll have a series of presentations. They'll be quite quick. We won't stop for questions at this point, but as you have questions, please put them into Slido, and we will look at how we integrate those questions into the panel discussion as well. So I will first ask for Vicky Brown. She's going to start the proceedings. So Vicky, over to you about the economic case.
Thanks, Jo, and welcome to everybody today. So today I'm briefly presenting on the economic case for preventing obesity in childhood. So drawing on the work from colleagues from the health economics stream, which is co-led by Professor Marge Moody from Deakin University and Associate Professor Alison Hayes from the University of Sydney. Next slide, please. Here we go.
Yep. Is it coming?
So, yeah, that's great. Thanks, Concetta. So a well-established economic argument for obesity prevention in the early years has been based on the potential for future health benefits and healthcare cost savings from the prevention of chronic diseases for which obesity is a risk factor and which generally present later in life than in childhood. And this is a really important part of the economic argument for early intervention. So some of our work has generated this type of evidence. So for example, we found that the lifetime cost savings and health benefits of early intervention could be really quite substantial if the intervention effect is sustained. And this demonstrates the need for that life course approach to prevention that we've already heard about, starting from a very early age. Next slide, please. So prior to the CRE, the health and economic benefits of early prevention that accrue within the child to adolescent timeframe were far less well understood. And this represents another really important part of building that economic case. So some of our early work found that the direct healthcare costs of children aged 2 to 4 years with obesity were more than 60% higher than those with healthy weight. We also found that children and adolescents with overweight or obesity have lower quality of life than children with a healthy weight. and that these differences in quality of life become more profound as children grow into adolescence, which we can see there on the slide, with children with healthy weight represented by that green line, and those with obesity, the red line. And this again really highlights the importance of early intervention. Next slide, consider. So in building the economic case, we estimated the cost of 8 early childhood interventions using a common costing methodology so that we could meaningfully compare the costs of these interventions. And the bars on this graph present the total cost per participant for each of the interventions. Next slide, please. And then to predict the costs and benefits of early intervention from childhood to adolescence, we built the EPOCH health economic model. And the way that the model works is that we input measurements of child BMI to the model. So either from a trial or applying known intervention effects to national population data. And every year a new BMI is predicted for each child until age 15. And the model also predicts the healthcare costs and quality of life accumulated in the same time frame. Next slide, please. And so by combining the evidence on the costs of intervention with that information from the EPOCH model, we have been able to conduct the economic evaluation of 3 early childhood interventions. And this allows us to weigh up the costs and benefits of funding an intervention or strategy to see whether it represents good value for money. And prior to the work of the CRE, there were actually very few economic evaluations of early childhood obesity interventions. So we just didn't have a lot of this evidence available to us. So we found that 2 interventions were cost effective. The prevention of overweight in infancy, or POI sleep intervention, which involved directed sleep guidance and some tailored components. And also Romp and Chomp, which was a community and early childhood education and care intervention in Victoria. In an additional study, we also estimated the cost effectiveness of the POI sleep intervention by socioeconomic position and found that the intervention was more cost effective in the low and middle SEP groups than in the high SEP group. Next slide, please, consider. So overall, our team has developed methods to facilitate high quality and comparable economic evaluations. We found that child overweight and obesity was associated with lower quality of life. We've identified 2 cost-effective early childhood interventions, and that cost effectiveness can be achieved across socioeconomic strata. And we've identified both the short and long-term health benefits and savings in healthcare. And all of this information contributes to building that economic case for early intervention over the short, medium, and longer timeframes. So now move to a Slido question and just wait for that to pop up. So we'd really like to know how important or useful are the results of economic evaluations to your work. So A, extremely important or useful, B is very important or useful, C is nice to have but not essential, or D is not very important or useful. And I'll just give you a minute to pop in your answer there.
Now, we have had a question in the chat about where to put your questions. So if you log in to slido.com and then use the hash EPOCH, and then you'll find the polls there, but also Q&A. I note sort of while we're seeing this unfold before our eyes, that we already have a couple of questions in the Q&A. You can vote on those, you can add others, and we'll come to those questions in the second half of the session.
And just turning to those results there, so obviously we're very pleased to see that these types of results are considered very important and useful. And I think this really highlights the need to further build on this evidence. But I'll now hand over to Annalena Zeidler from the NHMRC Clinical Trials Centre for the next presentation. Thank you.
Thank you, Vicky, and great to see very important, extremely important results. My screen is showing lots of weird grey. Is that the same for everyone? Yeah, I don't know, Concita, I think maybe it's finding presentation right.
Stop share and reshare. See if that's a problem.
Yes, this is better. Thank you very much. All right. Yes, as Vicky mentioned, I'm based at the NHMRC Clinical Trial Centre at the University of Sydney, and I will be presenting on behalf of EPOCH-CRE 1 today on our analysis of interventions to prevent obesity in early childhood. Next slide, please. So we've already heard beautifully by Louise the case for early child obesity prevention, so I won't dwell on this for too long, but just to bring back to your mind, 1 in 4 Australian children have overweight or obesity by the time they start school. So in order to prevent obesity, we need to start very early. However, prior to the start of the EPOCH-CRE, there was limited high quality evidence on whether these very early interventions are effective. And that's what Stream 1 set out to do, to generate such high quality evidence on effectiveness of interventions. Next slide, please. So to generate such high quality evidence, we used collaboration and innovative methods to find out if and how early interventions worked. So we used a methodology called prospective meta-analysis to bring together data from 4 Australian and New Zealand studies. As you can see in the diagram at the bottom of the slide, we had 4 studies that all prospectively agreed to work together to collaborate and share their data, which led to a combined data set of over 2,000 infants. So we went quite broad in our analysis, but we also went deep by using deep taxonomies and interviews to understand the interventions and their components in depth. So we went through all the intervention materials and talked to the facilitators and investigators to really understand the interventions and what worked about them and what not so much. Next slide, please. So this just briefly summarizes some of our main findings. First of all, and importantly, we found that parent-focused strategies that start very early, so in pregnancy or the first 6 months of life, are in fact effective and feasible in preventing early childhood obesity. So they did help establish a healthier weight at age 2, but also other healthier behaviors such as improved diet and less screen time. Moreover, they were more effective in communities with little existing support, which I think aligns quite nicely with Vicky's findings. We also found from talking to investigators how important it was in order to design effective interventions that can be scaled up to collaborate with key stakeholders, such as researchers, policymakers, and health service practitioners. When we looked through the interventions, another thing that sprang to mind is how diverse and complex interventions were. So no 2 interventions looked the same. They all had lots of different that these early interventions, unfortunately, are not enough. If we want to prevent them from fading out, we need a suite of interventions spanning the life course. And this leads us to all of these findings, lead us to the next slides of where we're going next with these findings. So now we're taking the methods that we previously used and expanding them to an international global level. So we're bringing together all completed, planned and ongoing trials on early childhood obesity prevention. And so far, over 45 trials with about 40,000 participants have already agreed to join us. We call our collaboration the Top Child Collaboration. And they've already started data sharing. And with all of these trials and all this data, the research questions we want to answer are which types of interventions work best? And are there some essential components within these interventions to really understand the different complex components? We also want to find out whether different interventions work for different population groups. So in Duplo language, so at the moment we have all these colorful, beautiful components here on the left-hand side, and we want to sort through them. We want to understand them. We want to understand what kind of mechanisms and components there are to prevent childhood obesity. And then we want to rearrange them into minimum essential components for different populations to find the smallest, most effective interventions for different types of populations. Next slide, please. So now, particularly with this future effort in mind, I have quite a complex question for you, and I'm hoping to get just a very simple answer in a word cloud, so just a word or 2. And what do you think we shall think about when we're co-designing these targeted, effective and scalable interventions, the interventions of the future to prevent childhood obesity prevention? And yeah, I'm looking forward to seeing what's coming in this Slido. If you can show us. Great, we already have a few responses. So I see things like culturally appropriate. I think that's really important to, again, have this population focus and think about different cost effectiveness. I think, Vicky, you really drove your message home here. Then we have things like the burden to participants. Yeah, I think that's also important to think about how can we make them smaller, which maybe also ties in with the cost effectiveness. So maybe we can find a less complex intervention, really find the components that are most useful for everyone. Sustainability, I think that really draws into some of that as well. Yeah, so really great responses. Luckily, we have access to these Slido questions afterwards, so I will look through them in detail and make sure I take them into account. But for now, I'd like to introduce Dr.
Before you do,
yes.
I'll just note that in the questions, there have been some questions around the issues of equity and different cultures. And so I think that in terms of Top Child, you've made some connection to that as well. And certainly we're seeing that in this slide. So I'll just note that those questions are there and we'll come back to those as well. But I just thought that it just all connected up so nicely that it was important just to make that comment now. So I'll hand back to you to introduce the next person.
Excellent. Yeah, that's really great. I'm looking forward to connecting this all back together. So I'd like to introduce Dr. Penny Love to talk about integrating early child obesity prevention into health services. Over to you, Penny.
Thanks, Anna. And hello, everyone. I'm Dr. Penny Love. I'm speaking to you today from the lands of the Wadawurrung people on the Bellarine Peninsula, and I'm based with the Institute for Physical Activity and Nutrition at Deakin University. I'm going to be presenting a snapshot then on the translation and implementation research undertaken by Stream 4 members of EPOCH under the leadership of Associate Professors Rachel Laws and Li Ming Wen. Next slide, thanks, Consider. So you've already heard from Annalena and Louise in terms of the context that currently we have 1 in 5 Australian children who present with overweight and obesity really early in life. So the establishment of unhealthy lifestyle behaviour starts early, it persists, and it's associated with poor health outcomes, but it is preventable. And we have multiple opportunities, as you can see on the slide, for intervention across the first 1,000 days, in particular through our health and our community services, and especially through our child and maternal health and dietetic services. Next slide, thanks, Consider. So our research in Stream 4 has focused on trying to understand what it takes to integrate implementation of interventions to ensure sustainability. And by that, we mean not only embedding the key intervention components and those elements that Annalena's mentioned in trying to identify the core ingredients, but more importantly, how we seek to achieve longer-term participant benefits. And so that's definition that is on the screen is one by Chambers and colleagues. And it really describes sustainability as a very dynamic framework. And perhaps the only constant is the fact that we will always experience some change. And in reality, when we are going to implement interventions under real world experiences, there's always going to be some form of adaptation that's going to happen in the real world context. So we're encouraged then as academics to use this as an opportunity to measure and to monitor what services and organisations do to adapt and to change in order to achieve this best fit of an intervention for their local context. Next slides, thanks, Consider. So we explored barriers and enablers to 2 evidence-based programs, which you had an early introduction to in the video at the start of the session. And we really wanted to unpack implementation and sustainability barriers and enablers for Healthy Beginnings in New South Wales and Infant in Victoria. And you can see on that slide, as I said, they are of a very strong evidence base. And they're very similar in terms of targeting first-time parents, Healthy Beginnings starting slightly earlier in the 3rd trimester, using home visits, and Infant using a group-based model of 4 sessions. The messages, as you can see in those boxes, cover very similar core messages, from early milk feeding through to introduction of solids, focusing specifically on vegetables, fruit and water, active play, and also the role of parents and child. And the delivery then is also leaning very heavily on our community and maternal child health nurse sector. Next slide, please, consider. So to unpack the implementation and sustainability components, we drew from the Consolidated Framework for Implementation Research, or CIFA, and we used qualitative interviews with management teams involved in the delivery of Healthy Beginnings, and we used online surveys and also qualitative interviews with trained infant facilitators. And we really wanted to know what was going on for organisations that had not started delivery, those who started and then ceased, and those that were continuing to implement. And you can see from that really busy diagram, there are 5 key domains, and within each of those domains are a number of constructs that are considered as critical for integration and for sustainability of an intervention program. So what I'm going to do now is ask Concita to take us to the Slido, and there's a Slido question that you will see, which is for you to maybe have a 2-second thought. If you were faced with implementing and integrating an intervention, which of those 5 domains really speak to you as a health service or an organisation, whether you have had experience or not with integrating programs? Is it at the intervention characteristics stage and how important the evidence base, for example, is? Is it the organisational inner setting? Is it the outer context? Is it the process? Or is it the actual individuals involved in the delivery of that? And I can see from the results, can you just go up just one for me, Consider, just to see above? 1, 2, 3. I can only see 4. Is there one? Oh, is there one further down?
Okay. Yeah.
But I think the highest one is the process, the implementation process. Great. So we can go back to the slide set if you wouldn't mind, Consider.
Yes.
So that's really interesting to reflect on the people in the room and their perspectives, and I'm going to look forward to going back to that Slido and actually unpacking that myself. But here are the results that we found from the work that we did with Healthy Beginnings and infant implementation. And you'll see some strong parallels here that across both interventions, the inner setting, that's the organisational perspectives, was paramount to successful implementation and integration, especially from the perspective of that implementation support and the leadership management support from internally, and how the organisation felt the intervention aligned to their service delivery, whether it was compatible, if it met their priorities. And in the case of infant in particular, the ability to adequately resource, in particular the workforce, to implement was important. Similarly, as well, across both interventions, individual characteristics, these are the characteristics of the implementers themselves, was deemed vital. Healthy Beginnings viewed this from the perspective of adequate knowledge and beliefs about the benefits of the intervention, and similarly with infant, but in addition, they were also importantly looking at having the right person that had those personal attributes and qualities to implement and to facilitate the sessions. And then some slight differences with Healthy Beginning. There was probably more emphasis put on the intervention characteristics itself and the ability of Healthy Beginnings to be very adaptable. And for infant, there was a lot of feedback that we received about the benefit of having an external policy environment that supported the delivery of the intervention. Next slide, thanks, Concita. So in conclusion then, we believe that our findings really mirror what we're finding in the literature when it comes to what it takes to integrate and sustain interventions. And you'll see from those 2 key papers, there are 10 elements of sustainability that the literature is really talking to. And our work in early childhood obesity prevention has shown that we would say very strongly those 4 dot-pointed items there are key. One being resourcing in the form of sufficient funding and staffing for coordinating delivery and implementation. Leadership, probably from 2 perspectives, one being at an organisational level with management support, embedding delivery into the role descriptions of staff, aligning the delivery of intervention to KPIs, but also leadership at a broader level using local government, local health service and statewide policy levers to embed change through that. And finally, through engagement, looking at key stakeholders that can help facilitate the endorsement, the referral, the recruitment, and the retention of participant numbers. So thanks for listening, and I'm going to hand over to Dr. Rebecca Byrne from QUT for the next presentation.
Thanks, Penny. So as Penny mentioned, I'm Rebecca. I'm from the Queensland University of Technology, which is in Brisbane on the lands of the Turrbal and Yagara peoples. And I'm presenting on behalf of our Stream 2 team, which is led by Professor Stuart Trost and Rebecca Golly. Thanks, Concita. Now, we know that gold standard and established methods of measuring obesity-related behaviours, such as dietary recalls, food frequency questionnaires, or activity monitors, provide valid and reliable assessment of these behaviours. However, these methods are really not feasible for use in many settings due to their length and their cost, their need for specialised equipment, and particularly the end user burden on people such as yourselves associated with administration and data processing. So for quick and robust measurement of obesity-related behaviours, brief self-report tools, which can be administered quickly and cost-effectively, provide a really attractive alternative. But to date, there have been no brief tools available, particularly for use with young children aged 0 to 5, that can accurately and reliably measure the 4 key obesity-related behaviours. That's diet, physical activity, screen time, and sleep. So we have developed the EPOCH Dietary Questionnaire and Movement Behaviour Questionnaire to support your routine and harmonised measurement of behavioural outcomes across research and practice, with examples such as evaluation of scaled up early obesity prevention programs, to provide evidence of efficacy of existing programs, population level monitoring of health behaviours such as integration into dashboard or routine indicator systems, and translation for use in healthcare settings such as referral and monitoring and direct feedback to families. Thanks, Concita. We used a rigorous best practice process to develop the suite of brief tools. So we started by combining information from systematic reviews of evidence and expert consultations to define the behaviours of interest. And this was followed by cognitive interviews with parents on their experience of completing the tools. So this multi-stage process identified what to measure and informed the question wording and design so that the tools are well understood by end users. In the final stage of development, we tested the tools with parents of young children to determine their validity and reliability. So parents used the tools twice over a 1 to 2 week period to determine the reliability. And they also provided data on their young children's dietary intake, physical activity, screen time and sleep using established reference methods so that the validity of the tools could be assessed. Next slide, please. The result is a suite of 5 tools with minor differences consisting of age-appropriate questions. So each tool contains between 7 to 15 items depending on the version, and each takes less than 5 minutes to complete. And they're designed to be used by parents reporting their children's lifestyle behaviours. So the EPOCH Dietary Questionnaire consists of 3 versions for infants, toddlers and preschoolers respectively. And the tool asks parents to report how frequently over the past week their child has consumed a range of food and drinks. And versions are very similar, just with some small differences to be age appropriate. So all 3 versions assess intake of food and drinks related to dietary quality and obesity risks, such as vegetables and whole grains, while the version for parents of children aged 6 to 12 months contains items related to infant feeding practices. The Movement Behaviour Questionnaire has 2 versions, baby and child. If children have not yet reached their walking milestone, parents would complete the MBQ baby, otherwise the parent completes the MBQ child. And these tools examine time spent in different activities over a typical day, such as active play, time watching television and using mobile digital devices, and sleep duration in both the night and day, with some additional items related to tummy time and restraint time within the baby version. So online survey platforms can be set up so that parents can complete the combination of the two surveys that are applicable to them, using something like branching logic, such that the parents, say, of a 13-month-old, for example, can enter their child's age, be automatically directed to the preschooler dietary questionnaire, then be asked another question as to whether the child is walking and be directed to whichever MBQ version is appropriate for them. Final slide, thanks, Consider. So the website is on this slide for your reference, and you can find more information about the online resources that we have to facilitate the use and adoption of the tools, such as things like data management, analytic protocols, and the contact details of our team. I also have a question on Slido. I won't get you to fill that in now, but just something to think about over the tea break, and please pop your answer in there, just to let us know what resources you might find useful that could assist you in implementing these tools, particularly in the primary care setting. And I'll hand over now to our final speaker, Emma Airsdale, who is a PhD candidate within the University of Sydney.
You need to unmute.
Well, that was embarrassing. Hi, everyone. I'd like to acknowledge the Yagara and Turrbal people on whose land I'm joining you from today. My PhD project looked at the policy levers for the early prevention of obesity in childhood. My methods used a combination of policy mapping and interviews with senior health department officials in every Australian jurisdiction. Next slide, please. A life course approach to the first 2,000 days includes support for parents and carers, but sometimes there can be too strong a focus on these discrete ages and stages, rather than thinking of them in terms of the life cycle. Next slide, please. We need to consider broader environments, equity, and the determinants for health, because parents make decisions for their children based on their own lived experiences, the environments in which they live, and the resources that they have available to them. But what we don't know is what mix of interventions we need to prevent obesity in the early years in order to maintain it across the life cycle. Next slide, please. The Commonwealth policy mapping found no national obesity prevention policy infrastructure and limited policies to support healthy food environments. These mapping results were supported by interviews which identified that the Commonwealth Government was committed to its deregulation agenda and preferred policies which support personal responsibility. This table on the right shows a summary of the policy mapping for states and territories. You don't need to know the details, but just to know that blue indicates a policy was found, yellow indicates policy infrastructure or scaffolding, which essentially means good potential for policy leverage, but not there yet, and grey indicates no policies were found at the time of mapping. The main points I want to discuss here are that no jurisdiction had policies across all of the areas identified, and even having a policy in place did not mean that those actions had been implemented. And secondly, despite limitations in evidence for specific interventions for health supportive environments, states and territories are pushing ahead to form policies in this space. Next slide, please, Consider. One of the ways they're doing this is through their local health promotion models, of which there are two types in Australia. In the first, health promotion activities happen primarily through their local hospital networks and do not have a requirement for local governments to participate in health and wellbeing. The second group have public health acts, which require local governments to take an active role in health promotion. The ACT also sits within this model because it acts for both levels of government. So these health promotion models working at the local level and mixed policy decisions at the state level have resulted in an eclectic policy landscape in Australia, which is not unique to prevention. The benefit of this eclecticism is that we've had a lot of policy experimentation. From the table in the last slide, we saw that at least collectively, all bases were covered between the jurisdictions. This presents an opportunity to leapfrog and allows for innovation within and between states. But what is needed are better ways for jurisdictions to learn from each other, to share, adapt, and scale up initiatives so that they are contextually relevant, but still have some consistency across the jurisdictions. There also needs to be sufficient funding to maintain health promotion workforce capacity. However, this has been difficult to achieve in Australia without national coordination. And since the loss of COAG, there are no formal mechanisms for intergovernmentalism. Next slide, please. Oops, maybe one slide back.
I think that was the last one.
I think you may have, okay, last one's missing, no big deal. This morning I received an email about a further public consultation for the National Obesity Strategy coming up later in this month and through to October. Details will be posted on the consultation hub in coming weeks. The upcoming National Obesity and National Prevention strategies represent a perfect opportunity to establish a national prevention agency. Obviously, such an agency isn't a panacea, but it could fill a significant structural gap. Such an agency could facilitate knowledge exchange by identifying shared problems and solutions across jurisdictions and support a meaningful exchange by finding the right people in the system to adapt, embed, and scale up. It could maintain connections between research and policymakers to design better research and reduce the waiting times for results through traditional publication and dissemination channels. It could be a funding source for safe to fail experiments and actively contribute to the development of evidence of what works in an Australian context. It could link up new experiments and stakeholders with existing ones who share common interests, such as rural versus urban environments, food access, and programs to support parents of toddlers or the early childhood and education and care sector. It could identify the what's next questions in a meaningful way for Australia. Finally, while we don't all need the exact same policies, we should really consider the structures of policy formation, especially around using consistent policy language and measures. A national agency could develop and utilise consistent policy language and measures for monitoring across the country. It could partner with state and territory agencies to identify where routinely collected data can be used to measure the effectiveness of environmental interventions. And we have lots of opportunities with new technologies and data linkage. And I think that's my time. So I'll hand back over to you now, Louise.
Thank you so much, Emma. And the next slide, thanks, Concita. Folk, you've heard about the work that we've done over the past 5 years, and we've tried to summarise that, but we're also looking to the future. And I just want to let you know that the University of Sydney is currently advertising a PhD scholarship for someone to come and work with those of us based at the University of Sydney in the early prevention of childhood obesity. So that would be for 3.5 years of the next 5 years that we have ahead. So please think about it. It's a reasonably short time frame. You've got till Monday week to apply. So if you're really interested, go and check. It's also on our EPOCH website. So please go and let us know. Now I'll hand back to Jo. Thank you.
Thank you, and a great opportunity there. So a good opportunity, and clearly a very supportive audience as well. So hopefully there's someone there who thinks, oh, that sounds just right for me. We're going to have a short break now, and I think it's good to have the opportunity just to have a screen break, but also the opportunity to be able to look at the questions that are currently there, as well as to voting on questions, adding questions, because the next part of the session we're going to be looking at the panel discussion. I'll be starting the panel discussion with reflections from the panel, but then hoping to get a really interactive discussion happening. So it's now, it's just a few minutes until 1, I should say. So let's reconvene at 5 minutes past. So it gives time for a stretch. So we'll see you at 5 minutes past, but please do look at the questions and we'll see you back here for the conversation.
Hello, Joe.
You made it, Veronica.
Hi, everyone. Finally got in.
I'm glad. Yeah, sometimes technology, you know, we can be complete, but sometimes it just trips us over.
Yeah, it said our Zoom departmental account needed updating, and I had to contact IT in the department. That's like a nightmare.
Well, miracles happen. All right, so we should be expecting people to be coming back. I can see we have all of our panelists here, so that makes me as the facilitator very happy. So as people are coming back, I think we'll get started. Wasn't it nice to have a little bit of a break there just to gather thoughts and to have the opportunity to look through the questions? It's certainly been very helpful for me as the facilitator. Before going to the questions per se, what I would like to do is to ask the panelists to introduce themselves. And so they will tell you who they are and where they're from, but they're also going to share with you like a moniker, which will give you a bit of a sense of the things that they care about. One thing that I will say is that, and I'm very grateful to our panelists because we have, just following on from the theme from Emma, we have an eclectic group of people who are very senior within their organisations, who have different perspectives on this as an issue, and so can make different kind of contribution to the discussion. So I hope that you find this part of the session enjoyable, interesting, but also that it helps us to have that discussion about what comes next. Just so that you know, the way that I intend to deal with the questions is that for each of the panelists, I've got a starting question for them. And where there are questions from the audience that sort of relate to that initial question, I'll bring them in there. And then also there are some questions that are very specific to the researchers. So it might be some clarification questions, and so I'll bring those clarification questions in a little bit later. But just to get you thinking too, in terms of the broader discussion, sort of once we've got through this first hurdle, this first part of the discussion, is that I'll be looking for themes around, you know, what are the implications of the research and where are the gaps? There's already been a few questions around, you know, relationships between researchers and policymakers and how that can work better. And then also that third theme around the future as well. So I will throw to Veronica, who's going to start the introductions from the panelists.
Thank you, Joe, and thank you, everybody. It's terrific to be here. So many people interested in this super important topic. Joe, just to check, when I introduce myself, and do you want me to give my little summary words up now, or do you do that later?
Oh, you can just say your name, where you're from, and your descriptor.
Okay. Okay, good. Okay. All right, here we go. So my name is Veronica Graham. I work in the Victorian Department of Health. I have two roles. One is I manage healthy eating and active living in the Public Health Division. And the second role is a job share role as State Public Health Dietitian for Victorian Health Department. So very diverse portfolio. We cover all sorts of things in terms of policy development, but most importantly, policy implementation using many different settings across the sector of Victoria. And I don't know how much more you want about the job. I guess in terms of who I am and what my belief system is, I'm passionate about early childhood, and my early life was paediatric nutrition and dietetics for many years, probably 15. However, if I used one word or two words, I think I'm allowed to describe myself, they would be a system shaker. And if I could have four words, it would be a system shaker non-health. So what that means is, we all know about policy and we talk about it a lot, but I guess my main interest is getting to the systems and changing the infrastructure or the underbelly of the systems with which we all operate. And that means using our government levers of incentives, change in specifications, or sort of requirements that go beyond policy in terms of how things get to happen. So that's me. Thank you. Joe, well, that's...
now it goes to the next person on the list. So in alphabetical order. So we're now...
Oh, I hand to... Yes.
You hand to Leanne.
Sorry, Leanne. Over to you. Here's the talking stick.
Thank you. Hello, everyone, and it is great to see so many people joined in to this workshop and showcase today. So my name's Leanne Lyoki. I work within the Australian Government Department of Health. My role is as Director for the Healthy Living and Food Governance section, and that's within the Preventive Health Policy branch. I really thank you for inviting me to be part of this discussion today, and want to congratulate the Centre on all of the important work and the earlier presentations. I'm joining you from Ngunnawal country and just want to acknowledge the traditional custodians. So a part of our section's responsibilities, we cover overweight and obesity policy, physical activity, breastfeeding and sleep, and of course work quite closely alongside our colleagues in the food and nutrition policy area. Acknowledge that there's probably a lot of people on the call today that are interested in the next steps to finalisation of the draft National Preventive Health Strategy and also the draft National Obesity Strategy. So Emma earlier mentioned the National Obesity Strategy, and that some of you on the line may have received an email today notifying that there will be consultation on the draft strategy. That will be in the coming weeks. The consultation hub on the Department of Health website has been updated to reflect that, and that will be where the strategy becomes available for comment in the coming weeks. Just want to clarify at this point, if I can, that is a strategy that's led by Queensland Health as the chair of the jurisdictional working group. The Commonwealth has been part of that working group right from the start and has provided input, and the Commonwealth will take on the role of summary and analysis of the submissions that come in from the consultation step. So that was a strategy that was agreed under the former COAG Health Council. There is a process for finalising that strategy that is through the Health Chief Executives Forum, which agreed on the consultation just recently, and the finalisation for the actual publication of the strategy that will be made by health ministers. On a more personal note, I guess, and my interest here, like the translation of research findings into policy and how we can really have some sort of quick collective visibility of the things that will make most benefit to us as policymakers is really critical. So I think with that, my 3 words or less are probably connector and collaborator. Thank you. And alphabetically, just have to go back to the list and see who's next. I think it might be Andrew.
Hi. Thanks. Sorry about my COVID hair. I really need a haircut. It's quite wild. Look, my name's Dr. Andrew Millat. I'm the Director of Evidence and Evaluation in the New South Wales Ministry of Health. So I'm part of a team that runs training programs for the Ministry of Health, Australia's longest running training programs in public health, biostatistics and Aboriginal population health. We also fund research. And we do evaluations of policies and programs for a number of branches and pillars within New South Wales Health. So we kind of get across a lot of activities, not just prevention and not just early childhood programs, but we do have a sort of broader role in the health system and informing that health system with evidence from research and evaluation. And in a previous life, I have worked in prevention. I've been a Director of Health Promotion at a regional level and was one of the architects of what is currently in New South Wales, the Healthy Children's Initiative, and sort of was working in the centre at that time. So I have, I suppose, a bit of experience in prevention history in New South Wales and have worked on things such as the initial iterations of the Australian Better Health Initiative and the National Partnership Agreement on Preventive Health, and injecting a lot of evidence into those processes. I'm also an adjunct professor at the University of Sydney. And I suppose if I was to describe myself, I'm a bit of a policymaker by day and a researcher by night and on weekends. So I try to sort of, wherever possible, take the work that we are doing in the Ministry of Health and partner with our research colleagues to get the work that we're doing published in the peer-reviewed literature. So if I was to sort of describe myself, really, I would gladly call myself a technocrat that tries to make the most of policy windows, because, you know, those of us who work in policy realise that we have lots of great ideas and we can't always apply them. We implement the government's of the day's agenda, but really, when you've got the evidence and the information together, you've got to make the most of those policy windows. So I'm a policy window person. That's me.
Thanks,
and
Andrew.
I think
Aruna now.
Hi everyone. So I'm here from New South Wales Treasury. I'm an executive director there, currently responsible for economic and revenue analysis, which includes a lot of our intergenerational work, including the intergenerational report that we just put out in New South Wales. But I've previously been in roles responsible for our national health funding as well as for health reform, and, you know, Treasury's interest and work in that national health reform space. I actually, a bit of an unusual person to be in Treasury. I'm a barrister by background and training, and my intro to the public health world was actually being part of Australia's defence team on tobacco plain packaging for a number of years. And so we worked quite closely with the Commonwealth Department of Health in terms of assembling the economic case for tobacco plain packaging when we were in the position of having to defend that internationally. So that's really where my passion for this topic area starts, and the area of preventative health. And if I had 3 words, I have a lot of competitors for those 3 words, but I think I landed on health inequalities crusader, because I'm really passionate about making sure that we deliver the highest quality of life across society. And to me, health outcomes are such a critical part of that.
Terrific. Thanks for that. So I'll kick the panel discussion off, in fact, by asking Aruna a question. Aruna's already mentioned the intergenerational report, which is a New South Wales document, but of course there are other intergenerational reports across the country as well. And certainly, you know, part of the landscape for government too is around a move to outcome budgeting. And so that's just a little bit of a segue into the question, which is, from your perspective and from a Treasury perspective, how can we best make the economic case for investment in early intervention and prevention, and what does Treasury look for when it comes to research and research findings?
Yeah. So the thing I'd start with, which I think I foreshadowed a little bit, is that, like, what's at stake when we're talking about preventative health is a central economic and fiscal concern for governments across the country and indeed across the world. Health is of significance to the things that we are trying to solve for at a whole of government policy level. And I don't think I can overstate that significance. It's a really important determinant of quality of life, which is ultimately, like, living standards are what we as Treasury are trying to achieve, like the highest possible living standards for the greatest number of people. Health is critical in terms of some of those core economic metrics we look at in terms of participation, but also in terms of distribution, because the ability of people to access the workforce, access education, and build their living standards depends critically on their health status. And then finally, which won't be surprising to you, health is critical in terms of our fiscal sustainability. It's our fastest growing area of spending. The fact that in developed countries we are aging puts greater and greater pressure on our health systems. It means that when you look at something like, any given intergenerational report, Commonwealth or state, health expenditure takes up a growing share of the pie, and it crowds out our ability to spend on other things. And therefore, there is a critical importance for societies to make sure that we're putting our health spending in the right place to produce the best outcomes for people, and not simply servicing health services at the acute at the acute end of the system. So that's kind of the framing, I think, at the macro level as to how you make that best case. In terms of what treasuries look for, and I know that Andrew will have perspectives on this as well from the health department side of things. But what I'd say is what we are and should look for is a robust valuation of benefits in research. So, what is the method around valuing either avoided cost or social benefits that you can bring when you're putting forward the case for investment, as well as the likelihood of benefits realisation, the likelihood of actually seeing the benefits that you expect from the particular investment. I'd add to that thinking about impact at scale. We see a lot of really interesting ideas at a small scale, and the question is always, well, what does this mean for the system? What does this mean at the universal level? And that doesn't mean there isn't a case for targeted intervention, but you need to make that case as to why this investment only makes sense for a particular cohort, because the automatic question is, if it's a really good thing, why don't we do it across the board and gain that benefit from scale? And then, one of the final things I'd talk about is really thinking about policy levers in the round and thinking beyond specific programs, but thinking about the full suite of levers that society has available. One of the things that happens a lot in the health space is that we're in the universe of talking about the third or fourth best solution to a problem. And then we go back to, well, hang on, why do we have this problem in the first place? These are the social determinants. Thinking upstream to what's the full scale of solutions, not because the particular solution you're talking about isn't a sensible one, but it needs to be understood and contextualized within a comprehensive suite of measures in order for it to actually shift the dial on health outcomes. And taken in isolation, it won't have the kind of effect that we need to see. So I hope that.
That's great, and I think that certainly that sort of concept, I've not heard it said in that way about policy in the round, is sort of very much sort of part of the underpinning principle of prevention. And I sort of think back to the initial video that we saw, which sort of talked about those sort of broader determinants as well. Certainly that sort of upstream focus is a very familiar thing in prevention and population health. But sometimes I think we can, as you say, sort of get sort of stuck on, particular interventions. And your comment around implementation at scale or impact at scale is a really important one, which there's been a lot of development in that sort of way of thinking too. And I know that within this group as well, and I'm sure Andrew will have something to say about this as well, is that the way in which interventions are designed for efficacy testing needs to have that sort of sense of, in the beginning, also considering how such an intervention can, if successful, be delivered at scale as well, because sometimes there's a mismatch between those as well. So, Andrew, I'm just wondering whether there are any sort of comments that you'd like to make in relation to that sort of concept of impact at scale. But I'm also, I'm just sort of scanning the questions here as well to see if there are any particular questions that people would like to ask in relation to the concept of robust evaluation of benefits, and also and the likelihood of seeing benefits, the benefits realisation side. Were there any particular comments on that? So Andrew, I'll just sort of hand to you to see if there's anything that you'd like to add. I'll have a quick look and consider if you could help me with that too. That'd be great.
Sure. I mean, I think one of the biggest challenges in health more broadly, whether it be in population health or clinical service delivery, is how you take interventions that are shown to be effective on a small scale and how you actually apply those across whole systems. And it's not as simple as sort of taking that intervention in its current form and then just applying it to a whole system. And we know that there are a whole range of organisational, there are logistical, there are political and contextual issues that really do have an impact on the ultimate effectiveness of interventions. And I suppose that's where the whole space of implementation and scale-up science kind of comes in. I think there's a growing body of evidence, and some of which was presented today, about the importance of giving consideration to, once a decision is made to scale something up, that there are a whole range of strategies that need to be put in place to ensure that interventions have the best chance of being effective, maintaining their effectiveness, being appropriate and acceptable to the patients or populations that we're hoping to target. They have to also as Aruna pointed out, they have to demonstrate benefits and have benefits realisation, because it's a very different thing from taking an intervention at a trial stage and how you apply that across whole systems, because all of the metrics change. You know, the workforce may change, the costs associated with that may change. You have to sort of look at the whole implementation and delivery system and actually have a different focus on it. And there's, you know, obviously a pathway, and implementation science is really where we're applying those scientific principles from multiple fields, from organisational change to, as I said, management, economics, and we take those multiple disciplines and we apply them to implementing things across whole systems. And that's really, so there have been very few examples of actually where we've done this across whole systems, and there are a couple that are sort of underway currently. A number of the programs implemented under the Healthy Children's Initiative in New South Wales are reaching anywhere between sort of 80 to 85% of eligible populations for some of the programs. We have value-based healthcare, which is sort of focusing on a whole range of models of care, which have been implemented at scale across the New South Wales health system, but they're few and far between in the national system and internationally. So the more learnings we can get and the more publications, the more information that we can share with the field about these things is really important to give people the opportunity to learn from those real-world examples.
Thanks, Andrew. Aruna, there's a question that's come from the audience. I feel like I'm doing Q&A. And that is that you mentioned the likelihood of benefits. Does this imply that research must do a better job at quantifying uncertainty when translating research results?
I'll start by admitting that I actually think health is one of those portfolios that struggles to a lesser extent from speculative benefits. I think there are other portfolios that have far more speculative benefits for the sorts of investments that they ask for. And in fact, I see it as a relative strength for health research in terms of making the case for investment, that you can point to, say, a particular health benefit in youth translating to an impact during adulthood, whereas for other areas of investment, that sort of 20-year time horizon can become highly speculative. So I didn't mean it so much as a commentary on the state of the research, but rather something that I think is important when you're thinking across different portfolios. How confident are you that the thing that you're talking about now will yield benefits over that medium and longer term horizon, because you know the transmission mechanism through which those benefits will be realised, versus other forms of investment, say a bridge, where like there's a lot of finger in the air calculations as to exactly how that bridge is going to yield benefits in 20 years' time.
And I think that also for me that sort of connects to the thought which was present in one of the earlier presentations, that that this work sort of demonstrates that it's not a single intervention, but it's sustained intervention at different points, which is going to be most beneficial across the board. We've started to talk about sort of the issue of scaling up, and this is a particular area for Andrew, so I'll go back to Andrew, but I'll ask Penny to talk about what INFANT, so INFANT is the Victorian program, and what they're currently doing there to scale up. And Veronica, being a Victorian-based panelist, you might like to comment on that as well. So Penny, I'll ask you to make some comments, then Veronica, I will get your perspective, and then I'll come back to you, Andrew, with a broader question around scaling.
Thanks, Jo. And yes, certainly Veronica knows exactly probably what I'm going to say. So yes, the infant program's really right now busy with the NHMRC funded trial, looking at exactly what Andrew mentioned. How do we take a evidence-based trial, intervention that we know from that efficacy perspective meets all the outcomes that we're looking for, but how do we take that to scale? So we're doing a effectiveness implementation trial, which is really complicated, and thankfully we have a great advisory group and stakeholders across the state engaged with that, because it is about working out how to have that parallel universe of researching but letting something go with your best support in place to assist, in our case, local government and maternal child health services to implement it through existing infrastructure, but it takes a lot of effort, and we'll have some data then at the end of that to show what happens when it goes to scale. But it is, I suppose, that next level of research that we need to see. I find it interesting, I suppose, the balance of conversation around needing to always, as an academic, go to the department with the evidence, and then the question is posed about, will that prove beneficial at scale, when we do actually see a lot of things that are picked up and scaled without evidence behind it. But I imagine there's a lot of discussion and decisions that happen. Did you want to add to that, Veronica?
Yeah, thank you, Penny. Infant is a classic example of working outside of the health system. So Infant really looks at how you engage with a universal system, maternal and child health, and the local government peak body, MAV, Municipal Association of Victoria. And I think in all of this policy implementation or practice or program implementation, if you don't fully engage those other sectors that will make the change, I think we're never going to get the change we're all wanting to see here. So that's the beauty and the challenge of Infant. And that bit about letting go is part of making that tailored to each setting. So we are going to learn what's going to work in terms of implementing Infant in different scenarios across metro, Melbourne versus rural and regional. So I think it's, and I have to say, Penny, the reason the state government funded Infant was because it did show an impact on evaluation with the trials that had been done early on. So it's a classic example of great work done by researchers in this space did in fact lead to funding the program and implementing across the state, or starting to. It's probably enough.
Thanks, Veronica. And I'll just make then the connection to, which I'm sure is in other people's minds as well, is that that sort of work that EPOCH's now moving to in terms of top child seems like a really exciting way to be sort of thinking about elements of intervention as well. I think that will be, providing some really useful evidence for the future as well, and certainly in terms of that sort of flexibility and adaptability. I'm now going to come back to Andrew and come back to his original question, which is actually less about scalability, but more about the issue of research translation and the translation continuum. And when we were talking before the panel, he mentioned the graveyard of good ideas. And I think sort of in sort of more sort of research terms, it's like the valley of death between the idea and actually getting the work into practice, or commercialization from a research perspective. So how do you sort of see the importance of embedding evidence in policy and practice as part of a continuum, and what does this mean for researchers?
Yeah, Joe, and I think the New South Wales Health has kind of given some hints to how it sort of conceives this concept of a translation continuum in our New South Wales translational research framework. So it's a framework that's been developed to accompany the New South Wales Translational Research Grant Scheme, but essentially sort of looks at the different types of research that are conducted out there in the research sector, starting off with research that really is often descriptive research that helps us to understand the scope and size of a particular problem. Then we have really interesting work where innovation occurs, and we have pilot programs, and we're starting to generate some evidence. The next step in that continuum is efficacy research, where there's a strong relationship between an exposure and outcomes, and they're often more randomized controlled trials. Then we have replication studies that show those efficacious interventions. They're trialed in different populations or settings. And then we have the next step is effectiveness studies, that really where we are trying to implement these things in systems, but they're under real world conditions using real world practitioners. And a good example of an effectiveness study would be, physiotherapists might be able to implement falls prevention activities, but in the real world, we don't have enough physiotherapists to do that. So we're using, people based in the community to run community exercise programs. So that's the real workforce ultimately, and we use that for an effectiveness trial. Obviously, the next step into this is in that framework is scalability, and then system monitoring, where we actually have implemented interventions across whole systems and monitoring the activity. So really that continuum gives a bit of a hint as to how the Ministry of Health conceives it, but there are many pitfalls along the way. One of the first pitfalls is that unfortunately, when we look at the peer-reviewed literature, the vast majority of that literature still is focused on measurement and descriptive research. So still about 80% of the research that's published in the peer-reviewed literature focuses on those areas. They're really important things, but only about 20% of that is intervention research. And some work by Luke Wolfenden, Rob Sanson-Fisher, myself, and other colleagues have shown repeatedly over the past decade that we still are getting very few studies that are focusing on intervention research, and in particular, those that are focusing on effectiveness and dissemination. So there are a couple of things that you can do to sort of, increase the chances of that research being adopted into policy and practice. And one of those really is ensuring that you engage policymakers, practitioners, and users wherever possible in the research that you're doing. It only goes to reason that by engaging people in those discussions and having a conversation about the types of research that are relevant, then actually implementing it in collaboration or in close partnership with policymakers and end users, that ultimately when those results are produced, that they're more likely to be picked up into policy and practice. And colleagues such as Mary Haynes and Laura Colley have kind of come up with this idea of what they call implementation handover. So at some point, no matter how good the ideas are that are generated in the research sector, at some point it needs to be adopted either at a state, national, or even across LHDs, where researchers sort of steps back into a more of a supporting role, and that policy teams have to take over and implement because they have the resources, the systems, the processes. So these are just some ideas that are floating around, but there is no one answer to this. But certainly the evidence is telling us more broadly that that idea of co-production wherever possible is a useful tool to then get that research adopted more readily. But it's easier said than done, because we know that's very difficult to engage very, very busy policymakers.
That's right. And that, in fact, is a beautiful segue to for my next question. And just to let people know, I'm very aware that there's a bunch of questions here, and we will get to them. There's a number of questions around programs, which once we've gone through the panel questions, I think we'll go to the questions around programs. But there's also a couple of questions around the measurement side as well. So we will go there, and then we'll get to the broader discussion around gaps, collaboration, which is already a strong theme, as well as the future. So the segue is for Leanne, and Andrew mentioned, busy bureaucrats. I mean, everybody's busy. I'm not, so I acknowledge that it's not just bureaucrats who are busy, but certainly, the current sort of context around the pandemic has had a significant impact on national, state and territory health departments, which have accentuated the challenges of working within government, including the need for timely evidence. So the question to you, Leanne, is what can help busy bureaucrats to engage with research and researchers?
Thanks, Jo. Yeah, look, certainly the pandemic has influenced the way we all work in terms of shifts of priorities and resources to support the response. Also, unfortunately, it's highlighted that for people who do have chronic conditions or are obese, that if they do contract COVID, there's a higher prevalence for more severe symptoms and poorer health outcomes. That adds to the case for action in terms of obesity. I guess viewed from another perspective, the focus that the pandemic has put on health and put it front and centre for the general public for a really sustained period, has allowed a platform for messaging on prevention, whether it's around healthy eating and getting enough exercise and sleep. So, we do have the possibility to build on that platform. But yeah, nevertheless, a very demanding and dynamic environment. And we often have to respond to recommendations on what initiatives are going to have the greatest impact at really short notice. So relationships are absolutely key. It's not the time when we get these time urgent questions to actually find out who the relevant people are. We already need to have the networks built. And that is something that, we've really worked on in recent times. So to have as well as the networks and to know the people to ask, to have some sort of database or mud map of different initiatives at different stages. So whether they're in pilots, whether they've been evaluated or not, whether there has been some upscaling, whether there has been expansion. I guess we're also interested in the longevity aspect. So not just the expansion or the upscaling of something, but is it more worthwhile to invest in that particular initiative on a small scale, but make it happen for 5 years instead of for 1 or 2? So I think, the role of economics in actually, making the case for one initiative over another, or, one initiative for longer is really, really critical. And, we have a number of strategies and pieces of work that I guess focus early intervention. So whether it's the National Breastfeeding Strategy, or we've just released guidelines around physical activity in pregnancy, the National Healthy School Canteen Guidelines, a number of different initiatives, and to have some help on, well, which ideas first and how can we stagger them? What's likely to have the greatest impact? That's kind of looking from a really pragmatic perspective. And, I think we're all heading in the right direction, and, perhaps the pandemic has given us opportunities to meet in different ways, collaborate in different ways, get more of a platform, and, we should, continue to work to build on that. Thanks.
Keep muting myself and then forget that I've done that, because I don't want you to hear the pings that come up on my computer. I've got one more question for Veronica before we actually move into the Q&A section per se. And Veronica, that I'm just noting that often research will point to the establishment of a plan or a government policy as a solution, or as a solution to chronic disease, one of the solutions to chronic disease prevention. Why do you think the policy challenge is a bit more nuanced, and how can research help?
Yeah, okay, thanks, Jo. A policy is just really some words on a piece of paper in its most simplest sense, and it really is nothing until it becomes implemented. So I do agree with Andrew 1000%. Researchers, each and every one of you, when you are planning your research, think about implementation research and helping us progress along the path about what actually works in the real world. That is very effective in this day and age, instead of a further deep dive of what is the actual problem, especially with something like childhood obesity. I think we know enough to sort of move it along. So that the first thing researchers can do is that, and that actually helps us sort of make the case to government in terms of what can we do, because the question governments and ministers need to know is, we've got the problem, what do we need to do? So if you as researchers can help us with that piece of the story, that is valuable. And the other one I just want to point out is the economic argument. It is so important, even if it's on a small scale. Whatever you can do to quantify the benefit and project it forward is super helpful, and it helps make that case about here is what we can see as a benefit apart from, healthier children. Here's how we can project it forward. And the other thing is research that's timely and nimble. In some cases, we've actually gone out to researchers and asked for some quick work. And I know researchers, you are very thorough, but sometimes we need a quick turnaround, and sometimes it's a matter of pulling some students we've done together to get a quick answer of what's happening right now here in this situation. And that's a helpful sort of pulse check. So it's not the peer-reviewed journal piece, but it does help us understand a little more of what's happening, given that things are changing quite rapidly for all of us in society and environment. That's probably enough, Jo.
Thanks, Veronica. I think that's a very helpful sort of part of the puzzle as well. All right, I'm going to turn us now to some of the questions from the field and or from the audience. And the question that has become the most popular one relates to the issue of reaching vulnerable community. So this is more from a programmatic perspective, I suppose. And so I will ask someone from the EPOCH team to talk about their reflections on this. There are also some questions in relation to the use of digital technology as a program, well, I'm presuming as a programmatic intervention as well. So I'm not quite sure who from the EPOCH team would like to take that question or that sort of suite of questions.
Penny first, and I can then fill in
Thanks.
later if needed.
I can certainly talk to vulnerability. So for both Healthy Beginnings and for infant, the trials and the work that's been happening now reflects the population groups in terms of those people who access our mainstream services. And, there's a high representation of culture and language across that, and length of stay in country in Australia for those who have immigrated. And there's another person and part of EPOCH who's actually, made that their PhD work, looking specifically at cultural adaptation. Concita, who's online, has looked at Chinese immigrant women. So we have been looking at cultural and linguistically diverse groups. And now in infant in particular, we're looking more at I suppose I don't particularly like the word vulnerable population, but we're looking at other population groups that we're not necessarily reaching. And that can include dads, it can include short or newly arrived immigrants. We're even looking at those who have gone through trauma in terms of refugee status. So we're certainly approaching it. My reflections, I suppose, working with our PhD candidate, who I'm sure is online, Sarah Marshall, is the process that one takes to do that really can't be a token approach of a language translation. It really needs to be that co-design, co-production, early engagement, community stakeholder engagement, and developed together. It's not, I don't think it's good enough for anyone to take an existing mainstream program and expect it to work for all groups. I don't know if you want to add to that, Concita, perhaps, because you've had some experience working with Chinese groups.
Yes, certainly. I think some of the determinants in the cultural groups, it's the same across, the mainstream population as well, but the way we approach the intervention would be a little bit different. So, for example, what I found in the Chinese women, for example, is that the role of family is very, very important. And so they need to be included as well, the extended family, I mean, so they need to be included as well in the intervention. Otherwise, it's just not going to be as effective. So there's definitely nuances like that we need to be aware of and included in the intervention.
Thank you. There was a specific question which was asked about within infant and Healthy Beginnings. Was there a focus on commercial foods? I'm not sure if anyone is able to.
No, the answer is no.
No, okay.
Very, very, very simple, straight,
right.
normal, healthy guidelines, no commercial foods at all.
Yeah, we certainly, it's all underpinned by our infant feeding guidelines, our dietary guidelines, which are then all based on, WHO and other evidence-based reputable information.
Terrific, thank you. Now there's a couple of questions for you, Rebecca, in relation to measurement tools. And I think that often having quality measurement tools often sort of gets overlooked at how important this is. So I think that the work that you've done is really significant in terms of, producing these valid tools that can be used in a short period. They're quick. So the questions that come from the audience around this is, the first is about the context within which the tools should be used. Are they for research or also for routine clinical practice? That's the first question.
So we can see them being used across multiple different settings. Particularly, with respect to dietary intake, measuring that in a research setting is incredibly complex. It takes a lot of time and a lot of staff time, so it can be very costly as well. So we can see that these tools can be used for researchers who would like to include dietary intake and aspects of dietary intake as a variable in their analysis to be able to pick them up and use them. But we then also do see, going to that almost not the complete opposite end, I don't know if that's the right phrase to use, but when clinicians and primary health care practitioners are having conversations with families, that they could use these tools in a number of different ways, actually quantifying children's different health behaviours, using them as a platform to start having discussions about the different health behaviours, and also indicators then to refer on to other programs and other programs that might be available, such as Infant and Healthy Beginnings.
Thanks. And the follow-up question is about the tool. Does it cover all of the food groups? And is it able to assess dietary quality or single items only?
So the answer to that is no, it doesn't cover all the food groups. Our first step in our process was looking at the existing literature and a lot of and consulting different experts in measurement of different health behaviours. We had a lot of robust conversations about what foods might be included and what might not be. But our brief was really to keep these tools brief and easy to use. So we just went, this is not about what we would like to know, but definitely what we need to know. And so as a result, it doesn't measure all different food groups. I can see Rebecca Golly is putting some information there in both Slido, and I've popped it in the chat as well, again on some more links where you can click through there to find out more information about exactly what's in the tools. The EPOCH diet tool contains the infant feeding for the baby version, vegetables, sugary drinks and discretionary foods are really the focus.
Thanks for that. There's quite a few questions around breastfeeding, and Leanne's already mentioned the breastfeeding strategy. Is there someone from the EPOCH team who's able to make a comment around breastfeeding and what we know well, as I say, there's quite a few questions about this. I'm not quite sure how we can quickly summarise that as an issue, but clearly it's an issue that is of broad concern to the audience. Louise.
I might just talk, I mean, I was involved with the Healthy Beginnings trial, which was in Sydney, and that one started antenatally. And its prime focus initially was to support breastfeeding. And that was, we had a series of developmentally staged messages, because, but clearly breastfeeding was the one that started antenatally. And we found that, so that was a core part of what we did. I know that those that started postnatally had as part of their messages to support continued breastfeeding. So we also, we were following standard, the Australian Dietary Guidelines, NHMRC guidelines and others, just to support this really important element of healthy early life. I might just, someone commented before about fat phobia, and so we never talked about obesity. We talked about promoting healthy infant feeding and then ultimately appropriate timely, introduction of solids, and then playtime, tummy time, keeping away from screens, that sort of stuff. So that it was just standard health promotion messages. I want to reassure people about that. And we weren't instead of existing early childhood services. We were supporting and encouraging in addition to those.
Thanks, Louise, and thanks for picking up that sort of issue around positive body image, and also being conscious of the potential for stigma and discrimination. I think that's really important. There were certainly a number of people wanting comment on that. I'm just sort of conscious that our time is almost over. And Emma, I've got a very quick question for you, and then I'll have a bigger question for panelists and the group to bring the discussion to an end. So a question from the audience is around, is there an international example of policy that Australia can learn from? So where would you say is the shining light from an international perspective in terms of policy statement?
That's a really tricky question. I think from a food system that is comparable to Australia's, Canada is a really great example of reviewing and having an ongoing approach to the reviewing of their nutrition and food system policy space. and being a federation, it means it's quite comparable to Australia in terms of funding and rollout and implementation and considering of those different actors. Again, prevention really is an ongoing beast. It's a moving beast. And so the translation and the uptake in Australia has to be really contextually specific, really thinking that Australia's population is 70% urban and 30% rural is a really key thing in the way that states and territories can learn from each other as well. And I'll stop rambling now.
I think sort of the number of questions that we've had, the number of, I think we could continue to be talking for a little bit longer, but we certainly don't have the time for that. So I'm going to ask the panelists, and I note that Andrew's had to leave, but that if EPOCH was to continue, what advice would you give the research team in building on the work to date? And perhaps also that sort of, because one of the really strong themes is about how do we get better policy research relationships as a sub-theme. So maybe a minute each for our panelists, your advice to the team. So maybe Aruna, if we start with you.
Look, I have to say that, you know, consistent with my interests, one of the most meaningful pieces that was presented today was the impact on quality of life, and that, like, the importance of sustained intervention, obviously, to achieve that. What I'd be really interested is seeing that rolled forward into how does this compare to other things we could be doing that boost quality of life, because I think that that's where, if we're trying to think about the policy significance of a particular intervention that's competing with all the other good ideas that are being put to government, quality of life is a really good platform for comparison. So for me, that was something I'd definitely like to see more work on, and see those findings rolled forward and explained publicly.
Terrific. Thanks. Leanne, your parting advice, the future?
Thank you. Look, continuing to build on the collaborations, I think, is key. I guess we're looking at it from a pragmatic perspective, and, you know, having those relationships in place so we can, you know, give the best policy advice based on the soundest evidence. Standardization of measurement, the focus on early intervention. We've noted the comments around breastfeeding, and the implementation of the National Breastfeeding Strategy is something that will get more resource behind it into the near future. So look, I would just welcome the opportunity to continue to work with the centre. Thanks.
And Veronica.
Hi, yeah, just to follow on what Aruna said, in terms of quality of life, very important one, but also the other co-benefits of related sectors, such as the climate change adaptation plans that governments are looking towards, and the dual benefits you get from healthy food and sustainable food. Those are really ringing true with both government, but also the general public. Certainly equity as well in there. So when you look at presenting your case as researchers, think about the other areas that are also benefited by this particular research that you're putting about early childhood, a better start to life. The other thing that's probably we all need to get on is get the consumers or the public really behind this, and how we do that and how we engage them in both the issues and the solutions, and how they become part of the voice. I think I'd like to see their voice elevated, and I know there are lots of creative ways that can happen. The other thing is, I do applaud you on the top child sort of concept, and that view that you're getting together as researchers and presenting a united front. That is so helpful to government. Resources are limited. There are many different voices. So when you come together as a group of early childhood researchers with something to say about a solution, definitely bring a solution and many voices. I think that goes a long way. Plus implementation research, plus economic arguments, and we're good.
We could continue this. We could continue this conversation for some time, but maybe we think about that. This is the start of an ongoing conversation. Sort of seems to be part of this theme as well, and something that's important to do. Louise, I'm going to hand back to you for the last 2 minutes to bring everything to a close.
Thank you so much, Jo. I do want to thank everyone who attended, because you've asked really interesting questions and you've made us realise actually this work is actually relevant to a large number of people. Of course, I want to thank the wonderful EPOCH team, which is scores of people now, including our those who actually presented today. This represents 5.5 years or more of collaborative research, and we're looking forward to another 5 years. So we're so excited to get your input. I particularly want to thank those who are invited as panelists today, Gina and Leanne and Aruna and Andrew, who's left, and Veronica. Thank you so much. You've made some really great comments, and I know it's not always easy as someone who's a policy decision maker to put yourself in the front line and to potentially be asked challenging questions, but you've been so thoughtful. And finally, I want to thank Joe Mitchell for, two other people I want to thank. Concita Kuswara, who's done so much behind the scenes work and who's a sort of key element of our CRE, who's done her PhD in this area and is actually working as a knowledge translation coordinator at the part-time with us as well. Thank you so much, Concita. And finally, Joe Mitchell, who helped facilitate this and brought together a great group of external panelists and helped us think through how we could make 2 hours work in a way that was relevant to so many people. It's really helped me tremendously. I've learned so much, and I'm so looking forward to the next 5 years, because you folk have given us some great ideas and connections that we can build upon. Thank you all so very, very much.
Thank you very much. Thanks, everybody. And 2 o'clock on the dot. Thanks again.